Imagine a patient comes into your clinic. They are, completely exhausted. Their blood pressure is just tanking, and they're losing weight rapidly.
Right, a presentation you'll see 100 times.
Exactly. And to figure out what is destroying their body, you don't actually need $1 million MRI machine. You just need to look really closely at the color of their skin.
Yes, that is the clue.
Because that single visual clue, whether their skin is unusually pale or inexplicably dark, that tells you exactly whether the physical collapse is originating down in their kidneys or, deep inside the center of their brain.
Which is really the absolute core of endocrinology, right?
Yeah.
We're dealing with these diagnostic muddy waters where symptoms are driven by this insanely complex communication network of hormones.
Right. It's all invisible signals.
Exactly. You might be looking at a factory overproducing a chemical, or, maybe a manager sending the wrong emails, or the shipping department just losing the packages altogether.
Well, welcome to today's deep dive. Whether you're a medical student prepping for the wards, maybe a young professional sharpening your clinical reasoning, or just an insanely curious, self-taught learner, you are about to get a masterclass in reading those invisible signals.
We have some incredible material to go through today.
We do. Our source material today is the Oxford American Handbook of Endocrinology and Diabetes. But we're not going to just sit here and read a textbook or rattle off a list of lab values.
Yeah, that wouldn't help anyone.
Right. We are here to uncover the why behind the pathophysiology. We're mapping out the complex feedback loops that connect, microscopic molecular biology to the actual living, breathing patient sitting right in front of you.
And to understand any endocrine disorder, you really have to start at the top of the command chain, which is the pituitary gland.
The master controller.
Exactly. It sits right at the base of the brain and basically dictates almost everything. But the mechanism here is, well, it's brilliant. It doesn't just turn on a hormone faucet and walk away.
Right. It's not just a steady stream.
No, the anterior pituitary communicates using highly specific pulsatile rhythms.
I always picture the endocrine system like a home heating system.
Oh, the thermostat analogy.
Yeah, like if the house is freezing, meaning you have a low target hormone in the blood, the thermostat, which is our pituitary gland, should be clicking on the furnace at max blast. It sends out stimulating hormones.
That is honestly the perfect way to look at it. But you have to remember that the thermostat has a schedule.
Okay, what do you mean?
Well, take growth hormone, for example. The major isoform, meaning the specific molecular shape of the protein the body uses most, which is the 22 kilodalton variant, it isn't released randomly.
Okay.
The pituitary secretes it in 5 to 6 nocturnal bursts, specifically during the early stages of sleep.
Wait, really? Just at night?
Mostly, yes.
Hold on, so if growth hormone is completely undetectable in the serum in the middle of the afternoon, how do we ever accurately diagnose a deficiency? I mean, do you have to wake a patient up at 3 a.m. for a blood draw just to catch a pulse?
Historically you could, but clinically today we rely on provocation tests.
Oh, got it.
Or we measure downstream products that have a longer half-life, like insulin like growth factor 1. The timing of the pituitary dictates our entire diagnostic approach.
Because you can't just take a random snapshot.
Exactly. And adrenocorticotropic hormone, or ACTH, it follows its own strict schedule, too. It peaks in the morning between, say, 6:00 and 8 a.m. to wake you up, and then hits its lowest point just before midnight.
Right, and ACTH is the signal that screams at the adrenal glands to make the stress hormone cortisol.
It is. And the molecular origin of ACTH gives us one of the most elegant clinical pearls in medicine.
This is the part I love.
Right. So ACTH is actually derived from a much larger precursor polypeptide called propiomelanocortin, or POMC for short.
POMC, right.
Think of POMC as a large block of clay.
Right.
The pituitary chops up that clay to make ACTH, but the leftover pieces, they don't just disappear. They create beta endorphins and melanocyte-stimulating hormone.
Wait, melanocyte-stimulating hormone? That's the chemical that tells the skin cells to produce dark pigment, right?
Precisely.
Oh.
So let's apply your thermostat analogy to a patient with primary adrenal failure, like Addison's disease.
Okay, so the adrenal gland, the furnace is physically destroyed, maybe by an autoimmune disease?
Right, so the house is freezing. Cortisol is effectively 0.
So the pituitary thermostat responds by just pumping out massive, desperate amounts of ACTH to try and stimulate the broken adrenal gland.
Exactly. And because ACTH comes from that POMC clay block, what else is happening?
Oh, I see. The pituitary is simultaneously pumping out massive amounts of melanocyte-stimulating hormone as a byproduct.
Yes, so the patient gets hyperpigmented, their skin turns dark, even in areas not exposed to the sun, like the creases of their palms or the inside of their mouth.
That is so fascinating. But consider what happens if the failure is secondary, meaning the adrenal gland is perfectly healthy, but the pituitary thermostat itself is what's broken.
Right. If the pituitary fails, there is no ACTH being produced at all.
Which means there's no POMC cleavage.
And absolutely zero melanocyte-stimulating hormone.
Wow. So a patient with secondary adrenal insufficiency will have the exact same fatigue, weight loss, and dangerous low blood pressure, but they will be remarkably pale.
Exactly. Just looking at the skin tells you if the lesion is in the abdomen or in the brain.
That's incredible.
Furthermore, in secondary failure, they don't develop hyperkalemia, which is dangerously high potassium,
Why is that?
because potassium is managed by a hormone called aldosterone. And aldosterone is regulated primarily by the kidneys sensing blood volume, not by the pituitary's ACTH.
Oh, right.
So the adrenal gland still makes aldosterone, keeping potassium normal, even while cortisol drops to zero.
Okay, I get the anterior pituitary doing all this complex rhythmic pulsing for growth, stress, and metabolism. But what about the posterior pituitary? Is it just like the overflowing parking lot for hormones?
No, not at all. It is simpler, but it's absolutely critical for minute-to-minute survival. The posterior gland handles antidiuretic hormone, or ADH, and oxytocin. ADH is the ultimate water manager.
Right, antidiuretics, so stopping you from diuresing or peeing out water.
Exactly. It acts on V2 receptors in the renal collecting tubules to pull free water back into the blood from the urine. And at really high concentrations, it hits V1 receptors in the blood vessels, causing them to clamp down and spike blood pressure.
Okay, so we've established what happens when the furnace breaks and the thermostat screams. What happens when the adrenal gland in this case, just decides to go rogue and pump out heat on its own, completely ignoring the thermostat?
Oh, that's when things get dangerous. When the adrenal axis is pushed into overdrive, you are looking at Cushing's syndrome, which is a state of chronic toxic glucocorticoid excess.
Got it.
But we needed to find a critical distinction from the handbook here. Cushing's syndrome versus Cushing's disease.
Oh, medical terminology loves to trip people up with slight variations like that. What's the difference?
Well, Cushing's syndrome is just the umbrella term for the clinical presentation of excess cortisol, regardless of where it comes from.
So you could get Cushing's syndrome just by, taking high doses of prednisone for your asthma.
Exactly. But if we're talking about endogenous Cushing's, meaning the body's making too much of it on its own, the handbook notes that 70 to 80% of those cases are caused by an ACTH-secreting tumor inside the pituitary.
Okay.
That specific cause is termed Cushing's disease. Tumors physically sitting on the adrenal gland itself only make up about 10 to 20% of cases.
Because weight gain and fatigue are incredibly common complaints in any clinic, what are the highly specific discriminatory features of Cushing's that should set off alarm bells?
You're really looking for the devastating physical effects of too much cortisol tearing down the body's tissues.
Like what?
The handbook lists moon facies, which is a pronounced rounding of the face as fat is redistributed.
Right.
You see spontaneous ecchymosis. The skin becomes so fragile that patients bruise heavily without any real trauma.
Just from normal daily activities.
Exactly. You'll also find violaceous striae, which are these deep purple stretch marks on the abdomen over 1 centimeter wide. And crucially, proximal muscle weakness.
Proximal meaning the muscles closest to the core of the body, like the thighs and shoulders.
Right.
So if a patient suddenly has to use their arms to physically push themselves out of a chair because their legs just can't do it, the cortisol is literally breaking down their muscle protein.
It's actively catabolic, yes. And remember, the adrenals also produce aldosterone.
Right, the water and potassium manager.
Exactly. If that specific cellular factory goes rogue and forms a tumor, you get primary aldosteronism, or Conn syndrome.
The Conn syndrome.
The handbook provides very specific triggers for when to screen a patient for this. If someone has hypertension that remains high, despite taking 3 different conventional blood pressure medications.
Which is refractory hypertension.
Yes. Or if their high blood pressure is paired with unexplained hypokalemia, low potassium, you absolutely must screen them for Conn's.
The test for Conn syndrome is actually one of the most fascinating diagnostic tools, I think, because it's not just a snapshot. It's a physical challenge to the system.
You're talking about the saline infusion test.
Yeah. You administer 2 liters of normal saline intravenously over 4 hours.
Right.
Let me translate the physiology of that for a second. You are rapidly drowning the system in salt water.
Basically, yes.
You're artificially skyrocketing their blood volume to force the kidney to hit the emergency shutoff switch. The kidney should sense all that fluid and completely shut down the renin-angiotensin-aldosterone system.
Exactly. In a healthy person, aldosterone would plummet to the floor.
But in cons,
If you measure plasma aldosterone at the end of those 4 hours and it remains above 7.5 nanograms per milliliter, the diagnosis of primary aldosteronism is confirmed.
because the adrenal tumor is completely autonomous.
Right, it's just blindly pumping out aldosterone and completely ignoring the body's frantic signals to stop.
We keep talking about tumors causing these hyperstates, but the adrenal axis is fundamentally our daily stress axis, right?
It is.
And stress isn't just a psychological feeling of being overwhelmed at work. It's a very physical cascade. The handbook spends a lot of time on the concept of allostasis. Can you break down the mechanics of what chronic stress actually does to human tissue?
Sure. So allostasis is defined in the text as a state of dyshomeostasis.
Dyshomeostasis, so fundamentally broken balance.
Exactly. It occurs from an inadequate, excessive, or prolonged adaptive stress response.
Okay.
Evolutionarily, stress activates the hypothalamus-pituitary adrenal axis. Cortisol spikes so you can fight or run away from a predator, and then a negative feedback loop shuts the system down when you are safe.
Right. You survive, the tiger's gone, you calm down.
But the problem is modern chronic stress. The system stays locked in the on position, and the resulting allostatic load slowly poisons the body.
Connect those dots for us. How does that chronic cortisol elevation physically override, say, the reproductive system? Because stress-induced infertility is something seen in clinics every single day.
It's a direct, brutal override. High levels of glucocorticoids actively suppress the neurons in the brain that release gonadotropin-releasing hormone, or GnRH.
And without GnRH.
The pituitary stops sending signals to the ovaries or testes. On top of that, high cortisol makes peripheral tissues resistant to whatever sex hormones are left.
Wow. So the body is essentially looking at the chronic stress and calculating, we are running from a tiger every single day. Right now is absolutely not the time to spend energy building a baby.
That's exactly the biological math. Practically, this manifests as stress-induced amenorrhea in females, the complete cessation of the menstrual cycle.
And in males.
You see plummeted luteinizing hormone and rock-bottom testosterone. The body just sacrifices non-essential survival functions, and it fundamentally warps your metabolism too.
Which bridges us perfectly from adrenal physiology into obesity and diabetes.
Yes, the metabolic consequences.
Because when you're running from a tiger, your body dumps sugar into the blood for quick energy. But if your tiger is just chronic work stress while sitting at a desk, that sugar has nowhere to go.
Right.
It just provokes a massive insulin response, eventually burning out the receptors and causing insulin resistance.
And the handbook actually digs into the specific neurobiology of obesity here. There is a peptide synthesized in the arcuate nucleus of the hypothalamus called neuropeptide Y, or NPY.
NPY, what does it do?
NPY is a tremendously potent appetite stimulant, but simultaneously, it reduces sympathetic nervous system output, which physically lowers your resting energy expenditure.
Wait, so it aggressively makes you hungry while simultaneously slowing down your metabolism?
Exactly.
That is a biological trap for weight gain.
It really is. And look at the regulatory inputs. NPY is increased by insulin, and glucocorticoids are stress hormone. And it is decreased by leptin, the satiety hormone, and estrogen. So when chronic stress drives up cortisol and early metabolic dysfunction drives up insulin, you are basically bathing the brain in signals that crank up neuropeptide Y.
It's a vicious cycle. Stress causes hunger, which causes weight gain, which causes more insulin resistance.
Precisely.
And that resistance is the hallmark of type 2 diabetes. But we have to expand our view beyond just the simple binary of type 1 being autoimmune and type 2 being lifestyle-driven, don't we?
Oh, absolutely. The text highlights a crucial genetic subtype called MODY, maturity onset diabetes of the young.
MODY.
Right. Typical type 2 diabetes is polygenic, meaning it's a messy, complex web of dozens of genes interacting with diet and environment. But MODY is autosomal dominant.
Let me translate that for the listeners. Autosomal dominant means you only need to inherit one single faulty copy of a gene from one parent to develop the disease, completely regardless of your lifestyle.
Exactly. And it accounts for up to 15% of youth diagnosed with so-called type 2 diabetes.
That's a huge percentage.
It is. And we are mapping the exact genetic defects now. MODY type 4, for instance, specifically involves a mutation on chromosome 13, which completely breaks the insulin promoter factor 1 gene.
So these patients are often lean, they don't have the typical metabolic syndrome, yet their blood sugar is sky high.
Right. It's a purely genetic structural flaw.
Regardless of whether the etiology is a lifetime of chronic stress or a single mutated gene on chromosome 13, when that patient is sitting in your clinic with dangerous blood sugars, you have to treat them.
You do.
So let's do a fast, mechanistic pharmacology masterclass on the oral hypoglycemic drugs based on the handbook.
Perfect. Let's start with the big one-aids, specifically metformin.
The classic.
Right, this is the cornerstone first-line therapy for overweight patients with type 2 diabetes. But its primary mechanism isn't actually about pushing glucose into cells. It's about stopping the liver.
Stopping the liver from doing what?
Metformin severely decreases hepatic gluconeogenesis.
Because the liver acts like an internal sugar factory, designed to pump out glucose if you are starving. But in diabetes, the signaling is broken, so the liver just keeps dumping sugar into the blood, even when the body is already drowning in it.
Exactly.
So metformin acts like a bouncer at the liver's factory door, just shutting down production.
That's a great way to visualize it. And as a secondary effect, it also increases insulin sensitivity in the muscle tissue. With long-term use, you expect a 0.8 to 2.0% reduction in HbA1c.
Okay, but is it safe for everyone?
No, there is a hard contraindication. You cannot give metformin to a patient with renal impairment, specifically a creatinine greater than 1.4, because it carries a severe risk of lactic acidosis.
Oh, wow.
Yeah, the drug builds up and shifts the body's pH to a lethal level.
Good to know. What if the diabetic patient is lean, and perhaps lifestyle isn't the primary driver?
For lean patients, the handbook points towards sulfonylureas. These operate on a totally different pathway.
How so?
They bind to specific receptors on the pancreatic beta cells, closing potassium channels, which changes the electrical charge of the cell and literally forces it to dump insulin into the blood.
So you are essentially whipping the pancreas to work harder.
Basically, yes. They are highly effective, dropping HbA1c by up to 2.5%. But because they force insulin secretion, regardless of whether you've actually eaten, the risk of accidental dangerous hypoglycemia is very high.
Right, you could drop their blood sugar too low. Then you also have the alpha-glucosidase inhibitors like acarbose.
Right, acarbose is a blockade strategy. It physically inhibits the digestive enzymes in the brush border of your small intestine.
Okay.
So when you eat complex carbohydrates, the enzymes can't break them down fast enough, significantly retarding the absorption of glucose into the blood.
So it flattens that massive spike in sugar you normally see right after a meal.
Exactly.
We have all these mechanistic tools, but to what end? What are the strict, non-negotiable clinical targets the handbook demands we achieve?
The numbers require rigid control. Fasting blood glucose must be under 7 millimoles per liter.
Okay.
The HbA1c target is less than 7.2%, though we push for less than 6.5% if there are already microvascular complications.
Got it.
And critically, blood pressure must be relentlessly managed to less than 140 over 80 millimeters of mercury.
Controlling the blood pressure in a diabetic is arguably just as vital as the blood sugar, isn't it?
It absolutely is.
Because the high sugar is already degrading the microscopic blood vessels in the eyes and kidneys. If you add high pressure hammering through those fragile pipes, they just shred.
Exactly. It's a recipe for organ failure.
We've focused heavily on chronic outpatient management, but endocrinology also happens at 2 a.m. in the intensive care unit.
Yes, the acute crises.
What happens when the entire metabolic system completely collapses? Like when a physical stressor breaks the camel's back and a patient spirals into diabetic ketoacidosis, or DKA.
DKA is a terrifying cascade. Without insulin, the cells are literally starving to death in a sea of sugar.
Right.
The brain panics and tells the body to start burning fat for emergency fuel at an uncontrollable rate, which floods the blood with acidic ketones. The blood effectively turns toxic.
So what's the move? The handbook must outline a protocol.
It outlines a very rigid, life-saving protocol. The absolute first step, once you've assessed the airway, is starting a 0.9% IV saline infusion.
Wait, you don't reach for insulin first.
You do not. You reach for volume.
Why?
These patients are profoundly dehydrated because the kidneys have been trying to flush all that excess sugar out through the urine, driving liters of water with it.
Right, osmotic diuresis. While you are hanging those fluid bags, you also have to play detective, don't you? People don't just slip into DKA on a random Tuesday. You have to find the trigger.
You must hunt for the underlying physical stressor. Surgery, severe trauma, an occult infection, or a silent myocardial infarction.
A heart attack.
Yes, and you immediately order arterial blood gases. In DKA, you will see a severe metabolic acidosis, but you will also notice a very low PASO2.
Right, because the patient is hyperventilating.
Exactly.
They're taking deep, rapid breaths called small breathing, trying to physically blow off carbon dioxide, which is an acid,
Mm.
through their lungs to compensate for the toxic blood.
And while you're doing all this, you also have to obsessively monitor potassium.
Ah, potassium again.
Yes. This is where the cellular mechanics are life and death. In DKA, total body potassium is severely depleted because it's been flushed out in the urine.
But the blood test might actually show normal or even high potassium, right?
Exactly. Why? Because the lack of insulin, combined with the acid in the blood, forces whatever potassium is left out of the cells and into the bloodstream.
So the moment you finally give that patient IV insulin to fix the blood sugar, you are opening the cellular doors. The insulin drags all that floating potassium back inside the cells.
Yes.
And if you aren't watching, the serum potassium level will suddenly crash to zero, instantly triggering a lethal cardiac arrhythmia.
It is a high-wire balancing act. Every intervention affects something else.
You mentioned a myocardial infarction, heart attack as a trigger for DKA. The handbook details a landmark critical care trial called the DIGAMI study that beautifully connects cardiology and endocrinology here.
Yes, the DIGAMI study. It looked at diabetic patients who suffered a heart attack and asked a really simple question. Does intensely micromanaging their blood sugar in the immediate aftermath actually save lives?
What did they do?
They utilized tight glycemic control. They forced blood glucose to stay strictly between 120 and 180 milligrams per deciliter using an IV glucose and insulin drip for at least 24 hours post-heart attack.
And what were the long-term results of just that 24-hour intervention?
Astounding, honestly. That tight control regimen resulted in an 11% absolute risk reduction in mortality at 3.5 years compared to the standard care group.
Wait, an absolute risk reduction of 11%? That's massive.
Clinically, that translates to 1 life saved for every 9 patients treated with this specific IV protocol.
Frame that as a narrative detective story for a second. Why does a heart attack cause such metabolic chaos?
Well, because a heart attack isn't just a plumbing problem. It is the ultimate systemic stress alarm.
Right. The heart muscle dies, and the body floods with cortisol and adrenaline to survive the shock.
And those stress hormones, as we discussed earlier, immediately block insulin and induce profound insulin resistance.
So the cells are suddenly starving, the liver dumps more sugar, the fat breaks down into acid,
Exactly.
and if you don't aggressively control that glucose with IV insulin, the resulting metabolic storm generates free fatty acids that cause fatal electrical misfires in the recovering heart.
It really connects to every single concept we've discussed today. The stress allostasis mechanism, the cortisol override, the insulin resistance, the fluid shifts managed by aldosterone and ADH.
Everything is connected.
Understanding the fundamental physiology makes the emergency pharmacology entirely intuitive.
That brings us to the end of our journey today, tracing the invisible signals from the microscopic pulsing rhythms of the pituitary gland all the way down to the life-saving fluid resuscitation protocols in the ER.
It's a lot to take in.
It is. But before we sign off, as promised for our medical learners, we have a quick review exercise to cement what we've covered.
Yes, let's test your diagnostic reflexes based on our deep dive today.
Okay, lay it on us.
Here is the clinical scenario. A patient presents to your clinic with profound fatigue, significant weight loss, and dangerously low blood pressure. However, on your physical exam, you note that they have notably pale skin, without a trace of the hyperpigmentation you'd typically expect.
Right.
Where is the physiological lesion located? And mechanistically, why is the skin pale?
Take a second to process the mechanism. Fatigue, weight loss, low blood pressure, but remarkably pale skin.
The answer is that the lesion is located at the pituitary level. This is secondary adrenal insufficiency.
Right, because the pituitary thermostat is failing.
Exactly. There is a lack of ACTH being produced. Without ACTH production, there is no need to cleave the larger POMC precursor molecule.
And without POMC being chopped up.
There is no melanocyte-stimulating hormone generated, which is why the patient remains pale rather than developing the dark pigmentation seen in a primary adrenal failure like Addison's disease.
A brilliant clinical pearl that relies entirely on understanding the molecular origin of the hormones.
I want to leave you with a final thought to ponder as you step back into your clinics or open your textbooks.
Go for it.
We touched on MODY today, maturity onset diabetes of the young, and how it accounts for up to 15% of youth diagnosed with type 2 diabetes due to a single dominant genetic mutation.
Right, the autosomal dominant one.
As whole genome sequencing becomes increasingly accessible and affordable, we have to ask, how many adult patients currently lumped into the generic polygenic type 2 diabetes category actually have highly specific monogenic defects.
Oh, wow. So we might have millions of patients trapped on standard treatment algorithms like metformin when their specific genetic defect might respond entirely differently to a targeted therapy.
Exactly. We are crossing the threshold into an era where endocrinology won't just be treating the organ
Sure.
or even replacing the hormone, but treating the specific gene. The entire landscape of classification is going to be rewritten in the next decade.
Incredible. Well, thank you for joining us on this intensive educational deep dive. We hope this masterclass empowers you to keep asking questions and connecting the physiological dots in your clinical practice. Remember, when you are dealing with endocrinology, the X-ray machine is useless. You have to learn to read the invisible symphony of signals playing out in front of you. Keep looking deeper.